Yes, yesterday we had a very a successful meeting talking about the different options we have today for post-transplant relapsed Hodgkin lymphoma. We know that most of the patients with Hodgkin lymphoma will be cured in first line, either whether they are in a localized or advanced stage with more or less intensive therapy. About 80% of them will be cured. But there's a small percentage that will be primary refractory and around 15 to 20% of them who will eventually relapse. And up until today, the standard of care for these patients is salvage chemotherapy and autologous stem cell transplantation. But in spite of different efforts to try to improve this strategy, around 50% of the patients will eventually relapse after autologous stem cell transplantation. So until recently, this was a very difficult situation with no new drugs available, and just to continue with chemotherapy would bring a very little efficacy and a lot of toxicity burden, especially hematological toxicity. So we have two new things. First, in an attempt to improve outcome after transplant, a randomized phase 3 trial, a placebo-controlled trial, was published with maintenance with brentuximab right after transplant. So patients included in this trial were patients with high risk of relapsing after transplant, and were patients who were primary refractory, who had relapsed within the first 12 months, or who had relapsed after 12 months but with stage 4 disease or extranodal disease. This group of patients would all go on to salvage chemotherapy, and they would be they would then see patients had complete remission, partial remission, or stable disease, and after 30 to 45 days after transplant, they would start consolidation. And what we see with a more than 4-year follow-up is that there is a great PFS benefit for the group that received brentuximab verdotin over the patients with placebo. The PFS had not been reached for the patients in the study arm. So this is a new strategy we have to improve the transplant and to improve this outcome for patients. But if patients eventually do relapse after transplant, the prognosis is really dismal, and we discussed 2 different retrospective publications showing that the overall survival after relapse after transplant is about 2 to 3 years. So the emerging strategies for treatment for these patients are brentuximab verdotin, and now it was published some years ago, where we see that there's a 75% overall response rate with a 35% complete response rate. And there's a subgroup of patients within the complete responders that maintain response, 53% maintain response after 3-year follow-up. This is a small group of patients. Some of them have been consolidated with allogeneic stem cell transplantation, so it's hard to make a clear decision on how to manage these patients, but this is another treatment option. And the other treatment options that patients have, especially if they relapse after VV, is the checkpoint inhibitors. So both nivolumab and pembrolizumab have been approved in many countries in Europe, in the States, and countries outside these regions. For these patients, nivolumab for patients relapsing after autologous stem cell transplantation, and pembrolizumab for patients ineligible for transplant or who relapse. And what we see with these new checkpoint inhibitors is that the overall response rate is around 70%, and the complete response rate is between 17 and 22%. But most patients have a very clear clinical benefit, and most patients will go on with therapy even after PR. So this is also a new option for patients. Some patients will maintain PR or even stable disease for many months. The PFS for the whole group was around 15 months, both for both nivo and pembrolizumab. So these are other options. What other options do we have is allogeneic stem cell transplantation. It's hard in this era of new agents to decide whether patients should be transplanted or not. But other things that we discussed is that BV in a published trial showed that as a bridge to allotransplant, can have a larger amount of patients achieve allotransplant in complete remission. So this is a very important prognostic factor, and it has also been evaluated by the Spanish group that it might influence in having less chronic graft versus host disease after allo. So we are witnessing a whole new era of improvement in patients who relapse after autologous stem cell transplantation, and these new drugs are having great influence in both PFS and overall survival for our patients.